The Michael Marberger meeting here in Vienna is really a unique meeting. Charlotte Charity has done a great job of integrating the science with the local history and culture of Vienna. It's a center point and crossroads in Europe, and similarly the meeting is sort of a crossroads in urologic oncology and a lot of what's new and going on around the world. So it's a very special meeting.
My talk today was focused on the development of antibody-drug conjugates in urothelial cancer. We've had dramatic breakthroughs in the treatment of bladder and upper tract urothelial cancers that have truly transformed the natural history of the disease, both in the metastatic setting and in the muscle-invasive setting. And we're seeing really probably long-term cures in a subset of patients with metastatic cancer which we've never really seen before.
It's a beautiful historic city. To be in this place, the birthplace of modern medicine, also is really exciting to me. The Michael J. Marberger meeting allows me an opportunity to connect with colleagues from around the world, but particularly those in Vienna who I've had an opportunity to get to know over the past 10 years.
Oh God, I've worked so long with Professor Marberger, and so many famous people were invited by Professor Marberger, and this is now continued by Professor Shariat. He really brings together superstars in uro-oncology, and when we can discuss and learn all the issues which we need to be established, and today one of these issues we wanted to discuss is screening. So Professor Shariat wanted to implement a screening program in Austria.
My topic is prostate cancer screening. We are randomizing men for screening at the age of 45 against starting screening with age of 50. We have very low prevalence rates at age 45 and a little bit higher prevalence rates at age 50. And the good thing is that such a risk-adapted screening approach is able to reduce overdiagnosis, which is still the main obstacle of every screening approach.
So I think that in the future, one field or one of the key points will be to educate the population to spend some time with our patients, much more than the one we are spending right now, and to explain clearly which patients, which cancers should be treated because are going to finish with the life of the individual, and which cancers are not going to kill the individual. So the men will die from other causes with the cancer, but it's not the cancer which is going to kill him.
I think the technology has matured, and nowadays patients can choose something which is sandwiched in between an active treatment and active surveillance, and an active treatment which is not so aggressive. And the new thing is that patients just want to preserve sexual functions and quality of life related to the avoiding. And I think that's what we have achieved in the past years more successfully.
I think this question of active surveillance is growing in importance because neoadjuvant therapy has become so effective that a lot of bladders that we're removing will no longer have cancer. And I think the potential toxicity of treatment outweighs the benefit. So we really have to come up with new paradigms for how we can restage the bladder to look for residual disease and then preserve the bladder in those patients who don't have any clinical evidence of residual disease.
We know that bladder cancer in the last years has experienced a lot of new advancements, especially in the advanced disease, in the metastatic disease. So I'm going to focus on my talk on the non-muscle invasive setting, which has recently had new advancements. In this year, 3 new trials so far, 2 positive, 1 negative, and also looking at the diagnosis and other things that we have for these kind of patients.
With AI, it's for the first time possible to understand and at scale how cells operate, how cells can be programmed, and how in particular immune cells react to the hostile tumor microenvironment. This is what we are using to design better cells, cells that can invade deeper, immune cells that can invade deeper into the tumors and kind of cure them or destroy them from the inside out.
This year I'm going to speak about
unleashing the endogenous power of exercise in cancer and beyond, because exercise is a very important tool where we can optimize not only the patient's outcome, but in general we have clear data that exercise is reducing the incidence of cancer and reducing the mortality of cancer. So I think it's a weapon that we should have used much earlier and much more over the years, and it's becoming increasingly important really to recommend to our patients that we should exercise, we should perform physical activity.
It's been a terrific meeting, very focused on genitourinary cancers, with a tremendous input from a multidisciplinary group of individuals, from urology to medical oncology, some radiation oncology, and really appreciate the discourse and the dialogue.
Shahrukh is of course a very good surgeon, urologist, and he always invites really interesting people, and I think it makes a very interesting program which goes from bladder to prostate. So I think both things are very important at the very moment now in urology. So it's a pleasure to be here every time.